Welcome to the Deep Dive. This is where we unpack complex, really core material and pull out the essentials you absolutely need.
Glad to be here.
Today, we're diving into something fundamental in pediatric nursing, the whole concept of atraumatic care of children and families.
Yeah, and this isn't just, theory from a textbook. It really shapes how we approach caring for kids. It's a totally different mindset from adult care.
Right.
So if you're prepping for clinicals or even just reviewing, getting this down is, well, it's crucial. Our goal today is to really break down four key things: the principles of atraumatic care itself, family-centered partnership, therapeutic communication, and health teaching strategies.
Okay, so let's start with the big term, atraumatic care. The source defines it as therapeutic care designed specifically to minimize or even eliminate the psychological and physical stress that kids and families feel in healthcare settings.
Exactly. It all boils down to that basic idea: do no harm.
And the chapter gives 3 concrete goals for this. What should we really lock in?
Think of it like a three-legged stool supporting the whole approach. First, prevent or minimize physical stressors. That's pain, obviously, but also things like lack of sleep, being stuck in bed, discomfort.
Okay, physical stressors, got it.
Second, prevent or minimize separating the child from their family. Keep them together whenever possible.
Makes sense.
And third, promote a sense of control. This is huge for the child and the family, giving them back some power in a situation where they feel powerless.
Right, let's tackle that first one, minimizing physical stress. The text gets really specific here, beyond just saying manage pain. It talks about using numbing creams for shots or IVs, things like that.
Yes, practical techniques.
But it also mentions something called therapeutic hugging as an alternative to, traditional restraints. How does that actually work?
Oh, therapeutic hugging is fantastic. It's smart both psychologically and physically. So instead of using physical restraints, which can be scary, a parent or caregiver holds the child snugly, maybe on their lap. It keeps the child secure during a quick procedure, like getting blood drawn. And the beauty is it uses the parent's presence, their most comforting resource, for positioning. Instead of some foreign, intimidating restraint, it lowers stress while keeping things safe.
Wow, yeah, that hits both the physical side and the emotional distress, doesn't it?
Exactly.
And speaking of safety, there's a really key clinical priority mentioned: doing invasive procedures in a treatment room, not the child's own room. This sounds critical.
It is absolutely critical, non-negotiable really, for psychological safety. The child's hospital room has to be their safe zone, their haven.
Right.
It needs to feel secure, predictable, a place for rest, play, comfort. If you start doing painful things there, the child learns to fear anyone walking in. Every time a nurse enters, they'll tense up, expecting something bad. That completely undermines their ability to cope, rest, and heal.
So keep the room safe.
Yeah.
Got it. And we often rely on specialists to help navigate these stressful times. The child life specialist, the CLS, what's their specific role? What non-medical help do they offer?
The CLS is such a vital part of the team. They're trained specifically on how illness and hospitalization impact child development. They don't give meds, but they do non-medical preparation.
Like what exactly?
Well, things like therapeutic play, using dolls or puppets so the child can act out fears or understand procedures. They teach coping strategies like deep breathing or distraction. And importantly, they support siblings too, because illness affects the whole family. They're basically the experts in making scary situations manageable for kids.
Okay, that makes sense. And that focus on the whole family, minimizing separation, leads right into the second principle, family-centered care, or FCC.
Precisely.
The book defines FCC as a true partnership. Child, family, healthcare team, all working together. Why is that partnership so foundational?
Because the family is the constant. Just think about that phrase for a second. Nurses change shifts, doctors rotate, specialists come and go.
Yeah.
But the family, they are the one consistent, unwavering presence in that child's life. They're the main source of strength, support, and knowledge about the child. Recognizing that is the absolute core of FCC.
That really resonates, especially thinking about longer hospital stays. So what are the core principles of FCC that guide our daily interactions?
The text boils it down to about 7 key ideas. Things like respect for the child and family unit, recognizing and working with their cultural background, supporting their choices whenever possible, giving honest, unbiased information,
Okay.
and then really focusing on collaboration and empowerment. We want families to feel like active participants, not just passive recipients of care.
And when we actually do this, what are the results?
The outcomes are pretty clear and positive. Lower anxiety for everyone, better pain management, sometimes even faster recovery times, and definitely improved communication and satisfaction for both the families and us, the providers.
So how does that collaboration look, practically speaking, day to day on the unit?
It means actively bringing the family into the care process, including parents in daily rounds, asking for their input because, they know their child best, maybe having family advisory boards help shape hospital policies.
Right.
And on a very basic level, it means providing decent accommodations so parents can actually stay comfortably. It's about being sensitive to all the disruption illness causes, emotional, logistical, financial.
Mhm. Okay. So the third principle was promoting a sense of control. And communication seems like the main tool for that, right? Building that therapeutic relationship.
Absolutely. Effective communication is everything here. It starts with the basics,
Yeah.
how we talk, how we listen.
What are some key verbal techniques?
Using open-ended questions, not just yes, no. Using reflection to show you understand their feelings. Paraphrasing what they say to confirm you've got it right and show empathy. Acknowledging their emotions, even the difficult ones.
And non-verbally.
Maintaining an open posture, uncrossed arms, maybe leaning in slightly. Good eye contact, though you always need to be mindful of cultural differences there. Nodding, just showing you're engaged and listening.
Now, here's something the source highlights that felt like a real aha moment. Jargon trap. We slip into medical terms so easily, but they can sound terrifying to kids and parents.
Oh, this is huge. We absolutely have to use plain language. Think of it like universal precautions for understanding.
What are some common examples the book gives? Terms to avoid and what to say instead.
Right, some key ones are don't say catheter, say tube. Instead of deaden, or heaven forbid, put to sleep for anesthesia, use make sleepy or special kind of sleep.
Okay, special kind of sleep. I like that.
Yeah, even simple words use pee instead of urine. For imaging, maybe picture or big camera instead of x-ray. It just removes that layer of scary mystery and potential misinterpretation.
That simple shift makes a big difference. But it's not just what we say, it's when. The timing of communication has to be tailored to the child's development. The source gives really specific timelines for preparing kids for procedures.
Yes, this timing piece is critical. Definitely something to memorize. For infants, it's all sensory, right? Touch, sight, hearing, cuddling, soft voices. Mostly you're watching them for cues of being overwhelmed, like if they turn away or shut their eyes.
Okay. But toddlers and preschoolers, that timing is different and really important, isn't it?
It is. For toddlers and preschoolers, you use play, dolls, stories. But the timing is key. Toddlers have almost no concept of future time, so you prepare them right before the procedure, like minutes before.
Minutes before, okay.
Preschoolers, they can handle a little more abstract thought, but not much. Prepare them about 1 hour before, any longer, and their imagination runs wild, often towards the scary possibilities. They'll just worry unnecessarily.
1 hour for preschoolers,
Right.
got it. Then school-age kids, they're more logical.
Right. They're more literal, they want to understand the why, use diagrams, let them handle equipment models if possible, and they need more processing time. Prepare them maybe 3 to 7 days in advance, let them ask questions, express feelings honestly.
3 to 7 days. And finally, adolescence.
With adolescents, it's all about respect for privacy, confidentiality, and their growing independence. Listen actively. Don't be judgmental. You can prepare them up to 1 week prior. And frame interventions in terms of benefits they value. Like, taking your asthma meds consistently means you can keep playing soccer without issues. Appeal to their desire for autonomy.
The whole week for teens. Okay, now before we leave communication, we have to mention cultural barriers and interpreters. This is a big ethical point.
Huge. You have to assess the family's culture. Who makes decisions? Are there specific dietary needs? What are their beliefs about health and illness? And if there's a language barrier, the rule is non-negotiable. You must use a trained professional interpreter.
Cannot stress that enough.
Never, ever use the child or other family members as interpreters. It compromises confidentiality, accuracy, informed consent, everything. It's a major patient safety issue.
And the book gives practical tips, like speak slowly, avoid jargon, even with the interpreter, pause often, and make sure you're talking to the family, not just to the interpreter.
Exactly. Maintain that connection with the family.
Okay. That whole discussion on communication flows perfectly into our last section, health teaching and health literacy. This is all about empowering the family, right?
Absolutely. Teaching is empowerment. And the process follows the familiar steps of the nursing process. Assess, plan, implement, evaluate, and document.
So when we assess learning needs, what are we looking for? It's more than just what do they need to know, isn't it?
Oh, yeah. We need to assess their readiness to learn. Are they in pain? Anxious? We need to figure out their preferred learning style, visual, auditory, hands-on, and identify potential barriers, cultural beliefs maybe, or lack of support at home.
And we need to remember we're often teaching parents who are adult learners. How does that change our approach?
Right, adult learning principles apply. Adults are usually self-directed. They want learning to be relevant to their immediate problems, they bring past experiences, and they're often goal-oriented. Our teaching needs to respect that.
Okay. Now, we can't talk about teaching without addressing a major issue, health literacy.
This is critical. Health literacy isn't just about reading. It's the ability to obtain, process, understand, and crucially, use health information to make good decisions about care.
And the stats are pretty sobering, aren't they?
They are. The source notes that nearly half of American adults have limited health literacy. That means potentially half the parents you interact with might struggle to understand instructions, medication labels, appointment slips.
Which means we, as nurses, need to operate using universal literacy precautions, basically assuming everyone might struggle and adjusting our teaching accordingly. How do we spot potential low literacy? Are there red flags?
Yes, there are behavioral cues to watch for. Things like frequently missed appointments, forms that are filled out incompletely or incorrectly, not following through on medication regimens. Okay.
Or maybe using avoidance tactics like saying, I forgot my glasses, or I'll read this at home, or just nodding yes without asking any questions. If you see these, you need to change how you teach.
So, knowing that people forget a lot of verbal info almost immediately, what are the practical things we must do to make sure teaching actually sticks?
Repetition is key. The rule of thumb is to repeat important information at least 4 or 5 times in different ways during a session. Slow down. Use simple, plain language, 1 or 2 syllables, no jargon.
4 or 5 times, wow.
Yeah. And teach in small chunks. Focus on the absolute survival skills first, what they need to know to get home safely. Use visuals, pictures, videos, color coding. Make it hands-on whenever you can.
Okay, so repeat, simplify, prioritize, visualize, interact, and then the final step, evaluation. How do we know they got it? We can't just ask, do you understand?
Definitely not. That question is useless. People often say yes, even if they don't understand, just to avoid embarrassment. Evaluation has to be active.
For skills, it's return demonstration. They physically show you they can do the task, draw up insulin, use an inhaler, whatever it is.
Okay. Yeah.
For knowledge, the gold standard is teach back or tell back. You ask the family to explain the instructions back to you in their own words. Or you give them a little scenario like, okay, pretend you're home and your child starts wheezing. What steps would you take? That's how you confirm real understanding and competence.
Teach back. That seems like the most reliable way.
It really is.
Okay, so let's pull this all together. This has been a really thorough deep dive.
Yeah, the big takeaways are atraumatic care is proactive. It's about preventing distress, not just reacting to it. It means minimizing physical pain and psychological stress, keeping families together. Family-centered care sees the family as the expert on the child and our essential partner.
Right.
And effective communication and teaching aren't optional extras. They're core nursing duties that absolutely must be tailored to the child's developmental stage and the family's culture and literacy level. It's about truly empowering them.
We talked a lot about timing, preparing toddlers just before, preschoolers an hour before, school-agers days before, and teens up to a week before all, to promote that vital sense of control. So here's something to think about as you take this into your practice. You have an anxious teenager who needs detailed information about a somewhat painful procedure. To honor their need for control, you need to give them that full week of preparation time. But how do you provide that necessary, honest information well in advance without letting that week become 7 days of escalating, maybe even debilitating anxiety? How do you balance truth, time, and minimizing distress? That's the kind of complex balancing act you'll navigate every day in pediatric nursing.
That's a great point to ponder.
Well, thank you for joining us on this deep dive into the essentials of atraumatic care for children and families. We hope this helps you integrate these crucial principles into your practice.
Thanks for having me. Remember, this approach truly makes a difference.